3, 2, 1. Sir, we are live now. Now we can start.
Okay. Good evening, everybody. Welcome to today's CME program brought to you by the Orthopaedic Research and Education Foundation, India. Today, we again have the privilege and the pleasure of having Professor A.K. Pal from Kolkata with us. And he's going to talk about OSCE, which is again the new format of examinations that one has to get used to. And he's going to mainly concentrate on pediatric problems and how to answer and deal with the OSCE questions that you might get. So I think without further ado, over to you, Dr. Pal. We'll look forward to an interesting meeting. Thanks.
Good evening, Dr. John Mukhopadhaya. So it's an external endeavor I have already told for the PGTs, postgraduate students, those who are appearing for the DNB examination. But this OSCE system is also come in a very big way, in other examination also. And those who are in appearing in the other system, in other system of examination like MS orthopedic examination, they will also get benefit because I will also discuss about the different techniques of cracking the OSCE and the questions also, and some concepts which will help for their going through the examination. Okay, so OSCE is basically, it is a objective type questions. There are some problematic questions are coming on, and this is also will come in our next curriculum, which will be advised for these next examination also. So that is extremely important. And as per NMC rules, they have concentrated on 60% on problem solving OSCE, and there are 30% is basically it is on some analytical OSCE, and 10% is for the just for the knowledge. So 60% is a problem solving OSCE, and so I will concentrate on that. So basically the OSCE, in OSCE we will check, the examiner will check the knowledge, this is the cognitive skill, check the psychomotor skill, and also check the affective skill also. So how do we crack this? So basic tips of this OSCE system is, so first of all, we have to read the hint from the problem statement. That is one. Second, allot 2 to 3 minutes, because every OSCE system you will get 10 minutes for total answering. So at least 2 to 3 minutes should be allotted for understanding of the problem. Next is the diagnosis and differential diagnosis, and check the breakage of the marks and time also, and then answer in brief. Now this type of OSCE. It has come in the last examination. So this sort of gait patient, the baby is crawling actually basically in his 4 limbs. So and the question is which gait it is. So what is the cause and the disease, importance of recognition, and ideal age for prevention and the treatment. Basically, it is a crawling gait. So in our orthopedics, so to keep our life simple, so we have to judge it whether this crawling is symmetrical or asymmetrical. So see this one, it is asymmetrical crawling. So this one may be symmetrical crawling, and this may be a crawling with a special character of like a bear, some animal, so it is crawling like that. So this is just a first hint is we have to check whether it is a symmetrical or asymmetrical. As you can see here, this one is asymmetrical. This limb is not going along with the other limbs, so this is asymmetrical crawling. So symmetrical crawling, the use of the hands and knees with equal distance. This is the most important. So sign of development. So what is the importance? Because this gait is basically this sign of the development of the motor skill. So basically there are two types of crawling, the gait abnormality, like crawling gait and the scooting gait. Crawling gait is maybe symmetrical and asymmetrical, I already told. And scooting gait is use of predominantly one leg for the mobility instead of the other leg. They're not, they're reluctant to use the other leg. So there may be some hemiplegic or some neurological variety. So in orthopedic point of view, so we have to concentrate on the crawling gait, which may be asymmetrical, or as you can see, this asymmetrical crawling may be improper muscle development. There may be curved spine or the scoliosis, shifted, there's a pelvis shift, the abnormal shifting of the pelvis and the hip girdle, there are visual orientation issues, and issues with the body awareness and balance when learning to walk. So what are the causes? Basically, this is asked in the OSCE. That may be due to autism, that may be cerebral palsy, hip dysplasia, or the pelvic deformity, scoliosis, and the vision issues. So these are the different types. You can this one crawling gait is the baby is looking like a bear. So it is a bear walking. Most important is the club crawling. So you can remember the different types, but basically the most important hints is whether it is a symmetrical or the asymmetrical crawling. This is most important. You have to keep it in your mind. Okay. So next is significance of the early diagnosis is the most important. So basically, if it is so you have to check whether it's a hitch crawl, that is imbalance, that is asymmetrical crawling. It may be due to the imbalance pelvis, one-legged crawl, that may be DDH, or there's a beer or crab crawling, as I already told. It is because of the cerebral palsy. Now, the cerebral palsy, basically, it is the diagnosis. Now, what is cerebral palsy? It is a basically, it is a disorder of the cerebral cortex, and a spasticity, basically, it increases up to 4 years, then gradually decreases up to the 12 years age. Prognosis for independent locomotion is favorable if the child learns sitting within 2 years of age. This is most important point. And spasticity leads to shortening of the muscle length on one side. That may lead to contracture if it persists for a long time of a joint, which with abnormal stretching of the muscle on the other. So, what are the approach to such of a patients? So, we have to identify whether it's a spastic child, whether it's an athetoid child, or the ataxic child. Spasticity is basically already told. So, there is some muscle tone is increased. There is a deformity as because of one side of the muscle is increasing tone, other side is normal. Athetoid is basically that the baby they will that will attend some typical abnormal posture. So that is the athetoid variety, and ataxic is the weakness. So patient is very unable to walk basically. So so we have to identify the muscles involved. That means there's basically the two joint muscles. Basically they are involved like flexors, the iliopsoas muscles, adductor of the hip, rectus femoris, hamstring, and these the gastrocolius. So basically, see all the muscles are the two joint muscles. They crosses the two joints. So then next is how to identify the spasticity and the contracture. There's another OSCE will be there. So I will discuss the difference between the spasticity and the contracture. What are the functional status? How to the functional status is classified? That is a gross motor function classification score, the GMFC score. I will tell how it can be, how will assess this GMFC score, and how to assess the tone, that is the Ashworth scale. Now, more than time limit for the treatment is ideal age for the treatment is reduction of the spasticity to be started 4 years. From the 4 years, I already told, and it goes at the height at to 4 years age, gradually to reduce up to 12 years. So before 4 years, no operation will become very much successful. So any operation, if you want to become some operate the child, so that should be treated after 4 years. Within that period, you have to do the passive stretching, the manipulation, tone inhibiting cast, orthosis, binaural block, like the perineural, the motor point injection of 40% phenol alcohol, or the botulinus toxin, 40% phenol alcohol, that puts a temporary blockage of the hypertonic muscle in the binaural junction. Whereas the botulinus toxin, a little bit longer effect. But now it is not done nowadays. There are another option is the intrathecal baclofen or selective dorsal rhizotomy. Now, the surgical treatment is considered after 4 years of age, up to 4 to 12 years of age. I've already told. Ideal age is between 5 to 7 years for the deformity or the unstable joint. That is what are the modes? Basically, they have either they weaken the spastic muscles, or some controlled release of the musculotendinous junction. Control, why control? Because if you release the whole contracted muscles, as the muscles is already weak, that means becomes very much weak, and that may produce the opposite deformity. So controlled release of the contracted muscles is required. Or maybe it triggers some elongation, controlled elongation, or there may be strengthening of the weak muscle, that is tendon transfer of the spastic muscle to the weaker side. Now, this is another case. It is a 4-year-old boy with history of premature birth and delayed milestone presented with crouch gait. So what is the probable diagnosis? As you can see here, the probable diagnosis is basically crouch gait, 4 years boy. So with this knowledge, it is a spastic diplegia. As you can see, both the lower limb is affected. Now, so basically it's a spastic diplegia. Now, which sitting attitude is shown in the picture and mention its clinical implication. So basically this attitude is basically it is a tripod. Patient cannot sit like this as because the hamstring, because the hamstring spasticity. So, because as you can see here, because the hamstring spasticity, patient is feels comfortable to keep the trunk lean backwards with both the hands supporting on the other side. So this is known as a tripod. You see, this is looking like a tripod. So basically it's a tripod situation, and that indicates it is a hamstring spasticity. Now mention the clinical test for planning for the management. It is a popliteal angle measurement. Mention the clinical scale for association and gradation of the involvement. It is a GMFC score, and for the tone it is Ashok scale. Now outline this approach of the management. See, this is the type. The answers are the spastic diplegia, tripod position, hamstring spasticity is a crouch gait. Basically, patient may produce with the crouch gait. Rarely, patient may come with the equinus gait, that is a toto gait with the equinus of that the ankle, or the jump knee gait. The clinical the test which is required, it is a popliteal angle measurement and the hamstring shift. What is that? I'm coming in the next slide. Now, what is the GMFC score in this case? As the patient can, Sebastian already told, see the clue. It is the patient is presented with crouch gait. That means patient is walking. So as the patient is walking, so without some as a crouch gait, patient have to take some aids with the help of the either by the parents or by the some bodies or with some aids. So basically it is GMFCS stage 3, because I'll come how the GMFCS staging can be done. I will come in the next slide. Now, what are the treatment is basically it's a hamstring, either it is a hamstring spasticity or the contracture. If it is a contracture, then it requires some release. If it is a spasticity, there are some several options I have already shown in our previous slide. If it is a hamstring contracture, it requires some medial hamstring release. If needed, simultaneous transfer to adductor magnus. In adolescent, it requires some distal femoral extension osteotomy. Now, the Ashok scale, I'm not going into detail. Now, GMFC score. See, this is the grade 1, grade 2, grade 3. As grade 1 patient is walking with some clumsiness. Grade 2, so occasional, it requires some support, but not any aids. Grade 3 says using some support, occasionally, not constantly. Grade 4 is its constant use of the, it is walking, but is a constant requirement of the walking aids, whereas the grade 5 is the non-worker. So in this case, we have to see whether the patient is an independent worker or a dependent worker or a non-worker. If it is a non-worker, straight away it is a GMFCA score 5. Now it is a dependent worker. That means it requires some aids. So it may be it's a grade 3 and grade 4. So if it is a grade 3 and grade 4, if requires aids constantly, then it is a grade 4. It requires temporarily. Sometimes it requires, sometimes it doesn't require. That means it's a dependent worker. So dependent worker is a grade 3 and 4. So it's a grade 3 if it requires temporary aids, and if it's a constant aids, it is a grade 4. Now, if it doesn't require any aids, so it is an independent worker. So that can be that can be treated by either by the several non-surgical options. So basically, why it is important? Because we have before starting any treatment, we have to score this, because by treatment we can change the from, at least we can improve from grade 4 to grade 4, grade 4 to grade 3, like that. If the patient has come with grade 5, we cannot make it as a grade 5 to grade 1. So counseling is extremely important. So at least improvement of one gate can be done with the help of the treatment. So that has to be counseled. So parents and the caregivers, they have some idea and expectation of that how much the outcome can be obtained. Now, the popliteal angle. So what is popliteal angle? How measurement? So the patient should lie supine. There's hip, knee, other side. This is the two types: the unilateral test and the bilateral test. Unilateral popliteal angle measurement and the bilateral popliteal angle measurement. Unilateral popliteal angle measurement is like this. Patient should lie supine. So it's see, as we that there is a hamstring contracture that is compensated by the lumbar lordosis. So that is the compensatory lumbar lordosis. So so we have to keep the lumbar lordosis intact by keeping the other hip and knee extended. So in this position, so if we make the hip 90-degree affected hip is 90-degree flexed, and suddenly we extend the knee, so the first catch is R1. If we sustained giving sustained pressure to extend the knee, ultimately it will ends this up to the second catch. It is the R2. So it's the first catch in an attempt to extend the knee suddenly. As why it is suddenly is why I'm using the word repeatedly. Sudden, it is because spasticity is a velocity dependent. So we have to make a sudden jerk to achieve the extension. So first catch is the R1 and the second catch is the R2 if we keep the sustenance of the pressure. So if the R1 is equal to R2, so that is basically it is a contracture. So if it is R2, suppose it is R1 is so this is the angle. Suppose it may be 0 degree or maybe 10 degree, 15 degree. Suppose you see this is a 60 degree. So this if the R1 is 60 degree, R2 is 0 degree. So that means it is spasticity, and that has to get treated by several non-surgical options. If the R1 is, suppose it is a 60 degree, R2 is 30 degree. So 30 degrees less. So 30 degrees the hamstring, it is a contracture, and that can be addressed. If it not treated properly, that has to be addressed. Now, what is hamstring shift? The hamstring shift is this compensatory lumbar lordosis is obliterated. So by flexing the opposite hip and knee, just similarly by the Thomas test. So we have to flex it so that this lumbar lordosis is obliterated. Now again, the orbital angle is tested. Now you can see here, this in R1 is 60 degree here, and R1 is only 15 degree, like maybe 15, 20 degree. So it is less. So basically, what does it indicate? So lumbar lordosis is corrected. That means compensatory anterior pelvic tilt is corrected. That means hamstring length is normal or long. So in this case, if we do the hamstring release, what will happen? Hamstring release weaken the hip extension or lengthen the hamstring. So if the hamstring shift, that means if after obliterating the lumbar lordosis, is the popliteal angle measurement is reduces, that is the contraindication for the hamstring release. So this is the importance. Now see this gate. See this gate. See this. This is a 4-year girl presented with difficulty in walking. See, check his foot. So identify the questions are identify the gait, suggest the probable diagnosis, suggest the clinical test to confirm the specific disease and the planning for the management, mention one conservative, semi-conservative procedure, one surgical procedure for commonest disease producing such gait. So what is the diagnosis? Basically, it's the toe-toe gait or the equinus gait or spastic equinus gait. Really, that is increasing hypertonia. That maybe there are two causes of hypertonia. It may be spastic hypertonia or it may be dystonic hypertonia. Really, it may be hemiplegic. Commonly, there is a spastic equinus gait, spastic hypertonia of the gastrosoleus. So spastic cerebral palsy affecting the gastrosoleus muscle is the one of the most important cause. Other causes of this toe-toe gait is a congenital equinus deformity, autistic child. So these are the causes. And again, if the child presents under 2 years of age, that may be idiopathic, or sometimes it is maybe habitual toe walkers. So that may be the cause. Now, what are the clinical tests for diagnosis? So we have to test the dorsiflexion of the ankle. Now remember this, what is it written here? Keeping the foot inverted. That means to exclude the valgus ex equino. Which term it is? Because if there's the tight tendo Achilles, that can cause the pes valgus, that is a valgus deformity of the heel. So we have to keep the foot inverted during the testing of the dorsiflexion. So that will negate the valgus ex equino. And also in the test, we have to keep the knee extended. So basically that is the exact testing of the dorsiflexion. So if the dorsiflexion is restricted, that means it is a true equinus, and then we have to test the silver scales test. Now again, during the silver scales test, we have to hold this, check this foot. We have to hold the foot, keeping the heel inverted, or in keeping the inverus, to prevent the valgus ex equino. This is the test. And after that, all of you know how to test the silver scale test. So holding the foot in this manner, we have to check the dorsiflexion, keeping the knee extended, and also we have to keep the knee 90 degree, whether the dorsiflexion is increased or not. So this is the silver scale test. Now, clinical test for planning of the management is detection of the spasticity and the contracture, is detection of the R1 and R2. Again, I am repeating, if the R1 is equal to R2, that means it is a contracture. But if the R2 is almost it is the normal side than the R1, that is because of the spasticity. Okay. Now, what are the treatment? Conservative treatment is passive stretching or central and peripheral muscle relaxation, tone-inhibiting cast, and orthosis. Semi-conservative is the phenol alcohol injection, I've already stated, or botulinous toxin injection. Operative is release of the musculotendinous junction of the gastrosolius, the Stier's technique. So this is these are the slide which is contributed by Dr. S.R. Bala. So I'm very much indebted to him. So this is a 18 months baby in photograph. As you can see here, this presented with lower limb deformity with radiographs at this is the 6 months age. This is the 12 months age, and this is the 18 months age. As you can see here, the patients at 18 months, this is the patient can stand with some deformity. Now the question is, identify the initial injury. This is a 6 months radiograph. This is the 12 months, and this is the 18 months radiograph. Now, question is identify the initial injury. As you can check from above down, as you can see here, there's something happening over here. As you can see, there is a fracture in the upper metaphyseal region. So this is the initial injury. And what is the recent deformity? It says the recent deformity is basically it's a unilateral genu-valgum deformity. As you can see here, it is a standing orthoangiogram. Clearly shows there is a genu-valgum deformity. Okay. Now mention the cause. What is the cause of this? So basically, it is a Cousins phenomenon. What is that? I'm coming. What is Cousins phenomenon? So if there is a upper metaphyseal fracture of a infant, and that will lead to ultimate genu-valgum deformity, and that is because of the Cousins phenomenon. What is that? That will come. Now identify the type of the radiograph in figure 3. So is a type of the radiograph in figure, basically it is a figure 4. This radiograph. This radiograph is basically is orthoröntgenogram. This is a figure 3 and figure 4 is basically is a orthoröntgenogram. So mention the prerequisites. What is the prerequisites of the orthoröntgenogram? It is asked in this question. It should be taken in standing view. And both the pelvis should, the anterosubilectron should be at a same level. It should be equalized. It should be at the same level. If it is required, some blocks may be required to keep under the heel, to keep both the anterosubilex spine at the same level. And not only that, the patella should look forward. So there are 3 criteria. Patient should stand, keeping both the limbs parallel as possible. Both the anterosubilex spine at the same level. Even if requires, some blocks can be placed under the heel of the affected part. And also not only that, the patella should look forward. It should not be rotated. So this is the criteria of the standing orthoröntgenogram. Now, ideal treatment of the initial injury. Now, I'll come. What is the ideal treatment? And treatment of the recent deformity. So, initial injury is a proximal metaphyseal fracture of the left tibia. Recent deformity is the genu-valgum of the tibial genu-valgum because of the tibial cause. And this is a Cousins phenomenon. What is Cousins phenomenon? I'm coming in the next slide. This is a standing orthoröntgenogram, and prerequisites are already told. The initial treatment. If the patient came in 6 months age with proximal metaphyseal fracture of the left tibia, it should be treated by a long leg cast with 3-point molding to maintain the reduction in a varus mold. It is also most important. We should not keep in the neutral or valgus. So it should be kept little bit varus, and that should be kept for the 6 little bit varus, not more than that's a 5 degree maybe varus. and for 6 weeks cast and non-weight bearing for to be maintained, and within that period serial X-ray to be done for 2 weeks onwards for recurrence of the valgus deformity even after the 6 weeks cast removal. So we have to keep the in follow-up at least 4 to 6 weeks interval for clinical radiological assessment for recurrence of the valgus deformity. After removal of the cast, we have to monitor for 6 months for detection of the developing valgus. Now, at 18 months of age, so what would be the treatment? Now, we have to wait and watch till 3 years, because that can be spontaneous resolution can happen within 3 years period. If persist after 3 years, then the option is the growth modulation. So what is Cosen's phenomenon? Cosen's phenomenon is described by the Ogden in 1953. There is a gradual flexion valgus deformity, and which is greatest between the 12 to 18 months post-injury. Resolution occurs usually within 3 years. Likelihood of the valgus deformity must be discussed with the parents at initial treatment and subsequent visit. So basically, Cosen's phenomenon is a late valgus deformity. It's a proximal tibial metaphyseal fracture. Etiology is unknown. So there are several theories. I'm not going into detail. So basically, about the initial treatment is already told. I'm not going into detail. Now, this is another case. It is a 7-year-old boy presented with progressive deformity of the left leg, following road traffic injury of the left knee and the open right foot injury. So open right foot injury. So identify the deformity of the left lower limb. So what is the left lower limb deformity? Basically, it is a genu varum deformity. As you can see here, the increased intermalleolar distance. So this is a genu varum deformity. Now mention two clinical methods for diagnosis and assessment of the deformity. For diagnosis, basically it is a inspection in anatomical position is sufficient enough for diagnosis. That is a increased intermalleolar distance, as you can see here. And also the anatomical axis or the plumb line. So plumb line is basically, if you plumb line drawn from the anterospheric spine, it will come through the center of the patella, and ultimately it will go downwards. It will touch the medial malleolus. So in the normal side, it will touch on the medial malleolus. Even in the affected side, if it is a genu varum deformity, so in that case, the medial malleolus will remain medial to that line. So that is a clinical mechanical axis measurement. Now detect the etiological factor as suggested in the radiograph. So as you can see, the radiograph is, so there's something is happening over here. These guys, you will see here, and the MRI is clearly suggested. There are some abnormality over this. See, this is the epiphyseal is the physis, and inside the physis there are some bar develops. As you can see here, this is a posterior medial bar. It is developed in the proximal tibial epiphysis. So basically, deformity is the tibia vera, the genu varum. Clinical methods inspection in anatomical position. There is a plumb line test for the clinical anatomical axis measurement, and also flexion test can be done to denote whether it is a tibial contribution or the femoral contribution. Now, etiology is basically either it may be loss of physis or loss of the fascial function, that is sick physis, or fascial arrest, that is a bony bar, which is the cause in this case. Last one is a confirmed after MRI with mapping. What is MRI mapping? I will show in the next slide. Now, options of the management is the fascial bar resection, repeated osteotomies during growth, epiphysiodesis, or that means the growth modulation, and the limb length discrepancy measurement. Now, factors for consideration of the management is lesion size, whether it's 30 degree or less, or at least 2 years growth remaining. And investigation needed is a lateral radiograph of the elbow for the proximal ulnar physis, and the radiograph of the phalanges for physis of the distal phalanx. If these physis are open, that means 2 years remaining growth is ensured. Another is the MRI mapping. So the first one is the plumb line. So you see this plumb line. Clinically, if we draw this plumb line from the anterospheric spine, it will go to the center of the patella, and if it is extended downwards, it will touch the medial malleolus. Whereas in the genu varum, the medial malleolus remains medial to that line. And another importance of the plumb line is from the posterior aspect. So if we drawn from the center of the occiput, it will pass through the center of the lateral cleft, and both the knee should be equidistant from this plumb line. So if the one limb is much more away, that means it may be genu-varum deformity, or if it touches with each other, whereas the ankles are away, that means it is a genu-valgum deformity. So this is the value of the plumb line assessment. Next is the mechanical axis deviation. As you can see, this is the central, this is the plumb line, and the mechanical axis deviation, it is a radiological assessment. I'm not going to detail because sometimes it is required. So this is the mechanical axis, is the weight bearing axis, center of the hip, center of the knee, and the center of the ankle. It will remain in a straight line. Is the mechanical axis, is the weight bearing axis, whereas the anatomical axis along the diaphysis of the femur and the tibia. Normally, there's a if we draw simultaneously the diaphyseal axis and the mechanical axis, is basically that the difference is 5 to 7 degree. That is why 6 degree external rotation is required for cutting of the tibia during the total knee replacement. Now, these mechanical axis deviation, see, as in this case, genu-valgum deformity. So you can see here the mechanical axis deviation. It is the horizontal distance between the normal mechanical axis to these the affected knee joints exact mechanical axis. So this is the exact deformity. If it is a varus, this mechanical axis will come much more lateral to that normal side, whereas in the valgus it will much more be on the varus it will go in the middle to the side. In the valgus it will go on the lateral side. Now, MRI mapping, it is extremely important because that area should be properly curated. So MRI mapping can be done in this manner. As you can see here, this part of the whole physis is affected by a bar. So another is this two radiograph is required to ensure that 2 years growth is remaining. So this is a lateral radiograph to see the proximal ulnar epiphysis, and see this is the radiograph of the phalanges. If this physis is intact, as Sanders et al. See, this is they have discussed, they have highlighted. If these physis are open, that means 2 years growth is remaining. Now, after this difficult OSCE, this is a very common OSCE we are encountered. Now, what is this deformity? As you can see here, this is a cubitus varus deformity. What is the commonest cause? It is a malunited supracondylar fracture. What are the expected palpatory finding? All of you know this is the thickened supracondylar ridge on both the sides. Mention the important finding on the shoulder. In the shoulder, there is restricted internal rotation at the cost of restricted external rotation at the cost of increased internal rotation. The mention of the clinical method of quantification of the deformity, it is the drawing of the carrying angle. If the prerequisites is maintained, that means the elbow is completely extended and fully supinated. Maintain the most commonly done surgical treatment. Basically, it is a lateral close wedge modified French osteotomy. So that is it is easy MCQ. Now this is another, we're going to be a little bit difficult MCQ. There is it is for mothers of 4 years baby complaints of sitting abnormally in this posture. Now mention the probable underlying causes. So it is sitting in a W position. So what is the probable causes behind the posture and the differential diagnosis? Identify the 3 clinical methods in favor of your diagnosis. Now come to this. So this is basically, it is an increased anteversion of the femoral head from idiopathic. It may be idiopathic, it may be DTH or the cerebral palsy. Patient will complain of the intogate. Basically, patient will complain that's a clinical finding. It's the intogate. There's increased internal rotation at the cost of restricted external rotation, and the basic test is the Craig's test. Now, approach. So what is the differential diagnosis of the intogate? Basically, you have to give if the traction in wide abduction in the 3 weeks, if you give that, so there, even after that we can check this. So basically 3 types of clinical condition which will responsible for the intogate. There is the increased anteversion of the femoral head, or other internal tibial torsion, or maybe metatarsus adductus. Now it can be diagnosed increase in anteversion. There is W pattern, as you can show here on W pattern of sitting. There is hip internal rotation is more. There is increased internal rotation at the cost of restricted external rotation. Craig stress positive, and great progression angle is abnormal. Now, increased tibial torsion is diagnosed by abnormal thigh foot angle, and metatarsal adductus is diagnosed as forefoot adducted. That means a too many toe sign, which is visible from if you inspect the patient standing from backwards. There are too many toe signs medially, foot border profile. There is concave medial border. So now basically, so next question is mention the age limit after which it requires some correction. So it is a 10 to 12 years, because within that period, every conditions, all the conditions may have spontaneous resolution. So we have to wait for 10 to 12 years before touching the patient for operation. Now, see, they mention the problems out of this condition if remain uncorrected. So if it remains uncorrected even after the 10 to 12 years, so there are some problems that are basically cosmetic, that is the intogate, anterior knee pain due to patellar instability, and this miserable malalignment syndrome. Basically, it is due to increased anteversion plus compensatory external tibial torsion. So basically, this combination is called miserable malalignment syndrome. Because of the increase in anteversion, there is intogate, and nature will try to compensate it by this there is external tibial torsion. So that is the abnormal the problem, that is the miserable malalignment syndrome. Next is the patient, they may have unstable hip, or ultimately that may lead to osteoarthrosis. Last question is specify the parameters for surgical intervention. So what are the parameters? So we have increase internal rotation of the hip. So we have to check the opposite movement. If the opposite movement is restricted, but at least 20 degree is persisted, then we don't have require some treatment. So increase internal rotation, but if the external rotation is 20 degrees preserved, then we don't require treatment. Similarly, if it is a retroversion or this is a slip capital femoral epiphysis, so if there is an increased external rotation of the hip is associated with at least 20 degree internal rotation, we need no treatment. So basically, this is the theory. And see this is the theory. The clinical feature is internal rotation. As you can see here, internal rotation is more, and in respect to the external rotation, we are suggesting increased anteversion, internal tibial torsion that can be diagnosed by just for keeping this plumb line from the center of the patella, and see this is that it is almost coming to the center of the ankle. So this is not the anterior tibial internal tibial torsion. And metatarsus adductus, we have to check, asking the child to stand, and the examiner will stand behind to check whether too many toe sign is visible on the medial side. So standing the patella facing anteriorly, sitting posture, you have to check the rotations of the hip and thigh foot angle to rule out the internal tibial torsion. Now, plan of management of increased anteversion is we have to check whether it is below 10 to 12 or above. So if it is the internal rotation is more than 80 degree and external rotation is less than 10 degree, that means proximal face is open or closed with hip instability. If there is it is not there, that means we have to observe it. But if this condition is there, then we can do this surgery. So what are the surgery? There's a corrective intertrochanteric derotation osteotomy of the femur with blade plate fixation, or corrective derotation diaphyseal osteotomy with antegrade nailing, or hip stabilizing procedure as hip instability is there. Another important point is if these are not there, but with external tibial torsion, we check whether the patient is complaining of anterior knee pain, as this patient is complaining of, and that may be the feature of miserable malalignment syndrome, and basically is due to the patellar instability. So if the patellar instability is not there, but the patient is complaining of anterior knee pain, so we can do the corrective or derotational osteotomy of the femur plus supramalleolar rotational osteotomy. But if the patellar instability is present, then we have to do the supracondylar femoral derotational osteotomy to keep the patellar tracking normal. and for patellar realignment or the supramalleolar rotational rostrum may be combined along with this. So this is the plan of the management of increased anteversion. I think we'll stop here and we can have some questions from the participants, and after that we can there are several OSCEs are there, we can continue again. Over to Janki.
Yes, sir.
Okay, thank you very much, Dr. Pal. That was great. We will take some questions, hopefully.
Yes, sir.
Yes.
While we are waiting, sir, can you let us know that which area of specialization is more commonly asked in OSCE?
See, I've already told, now the trend is 60% is problem solving. So they will give some questions. So from the questions, we have to make some answers, clinical methods, what are the investigations, what are the plan of management, what are the factors behind planning. This sort of questions will come in a majority. Next will come some problem solving questions from the radiograph. Suppose one radiograph is given, and from the radiograph some questions are what are the problems are there, what are the clinical probability, what are the factors to be considered before management, like this. And last of all, there are some knowledge type of questions, like some public harness is given. A baby is wearing public harness. So now the question is, what is this? Now, what are the factors to be checked before applying this? What are the straps to be applied first? What are the complications, like this? So these are the basic pure knowledge. Or there are sometimes some questions are asked regarding to check the counseling. Suppose there is some pseudo-orthosis is given. Now, what are the points to be counseled before putting the scalpel to the patient? So what are the points to be counseled? So these are the questions may be put in this. So these are the 10%, but 60% is the problem solving variety. So because some clinical problems, and then they will ask to solve the problems.
So one more thing, sir, because most of the person is not scoring more than 50% marks in this OSCE. Why is it so, sir? Because although when I asked the DNBs, they told they have written everything, but still they are not able to score 50%.
Yes, actually, they have written that just written writing is not sufficient enough. We have to write it to the point, and which answer is asking for that. Suppose I have already told one child is sitting in his tripod position. What is the diagnosis? If the child, if the student writes, it is a what is the diagnosis? A patient may have cerebral palsy. Now it will give half marks maybe, because it is a not complete diagnosis. It is a cerebral diplegia. It was spastic variety of cerebral palsy with cerebral diplegia. This is the complete answer. So that is why some instruction is given for these examiners to check whether the complete answer is given or not. If the complete answer is not given, they may be awarded half marks, sometimes 1/4 marks. Otherwise, if it is suppose that is a patient is walking with some equinus gait, so if the patient may sometimes may write that it is a the paralyzed foot, like that. So or that is a CTEV, patient is CTEV gait. So this is not the actual answer. So we have to exactly write this idea. It is a equinus gait. So this is actually the answer. This is a equinus gait or toe gait. So basically, these are the terms usually written in the book. So we have to use this actual term for the answer for getting the full marks.
So I asked to just John, sir, how to make it little simplified, sir, if the DNB board can consider something to make it, because even with this type of a system, about 90% of them are not able to score 50%. How to make it little simpler, sir?
And how do you make it simpler? I think that's how you score the questions will be something they have to look at, huh? Because it's not the fact that the questions need to be simpler. I think the scoring system has to be more amenable for getting better marks.
Yeah,
because beyond ways to get better marks in OSCE. I think this is a
no, sir, because whenever I used to ask, even the very good students are
No, because I remember 2 years ago when people did the OSCE, they got pretty good marks in the OSCE.
yeah.
It's not
But,
something very
but
simple.
now it is getting little tougher. I don't know. I think
Actually, I know that I sometimes I have an idea. Actually, basically, those who are appearing in the DNB examination, actually they are coming from a very busy orthopedic unit. So they are getting very little time to check the patients. So actually, which is required in this OSCE. OSCE is required some clinical solution. So, but most of the DNB students, they are basically they're indulged in operations. They are squeezed for different works and in the wards in the OT. So they're getting very little time to analyze the clinical problems. That is, I think, this is the main problem. If they
Let's don't
practice, I think that
forget
will be
this.
easier for them.
Let's not get into this right now. I think it's more important that they ask questions which they will be benefiting from. I don't think by discussing anything here we are going to gain anything. Okay, so in terms of we can't change what the DNB is doing. We'll have to
yes.
talk to them separately.
So I think if anyone have some question, you please ask right now. Otherwise, it's, I do not have anything in the chat box right now, sir.
Okay, great. So
So
in that case, thank you very much, Professor Pal.
Thank
I
you.
think we need to uh, understand what it is in the questions that people are not being able to answer and look at that rather than, I'm sure, because there are set marks for each part of the question.
Yes, yes.
And so if the students answer them correctly, they should be getting the marks for it. So we need to really look at that.
okay, so
Just
sir,
before
just
leaving, I'm just going
You
going
asked about how
some
should we prepare for
tips.
yeah,
ward
one
round
question.
part of OSCE.
Yeah.
Pardon?
How should we
So
prepare for ward rounds part of OSCE?
Yes, word round. Yes. Actually, if you go through this OREF, OSCE, the different programs, in the previously I have shown it this OREF in one program. There is a patient is lying down in a bed with some different gadgets are attached with him, like the one catheter is put, one traction is given, some saline is given, some Eurobag is given. So the question is, what is the exact position of the catheter? Is whether it is fixed or is properly fixed or not? Catheter, urinary catheter should be ideally fixed to the lower abdomen, is not to the thigh, because to keep if it is a male patient, to keep the normal curvature of the urethra, we have to ideally it should be fixed to the lower abdomen. So this sort of questions. So,
It's not just the curvature of the urethra, it's also the fact that the limbs are moving. Okay, they
absolutely,
could be
absolutely,
moving the
absolutely,
limbs, and
absolutely,
then the catheter, if it's stuck to the limb which is moving, will cause problems. So the
absolutely,
advantage of sticking it to the abdomen rather than the limbs is the fact that the abdomen won't move the same way and
absolutely.
to move with the urethra, so that should not be a problem.
Absolutely. So these sort of questions I have already given in that clue. And again, if you require, I can give in his ORF program again. So now, and
I
in that
think I think the ward
step,
rounds again is there are a number of things that you need to look at in the ward rounds. One is things like dressings, traction, casts. So all the devices that are used for traction, including the Thomas splint and the Buller Brown splint, the Crutchfield stongs, etc. One should have a good idea about. How do you apply skeletal traction? How do you maintain skeletal traction? How those are the things that will get asked in the ward rounds part of the OSCE. Okay.
yes. And also for the assessment, there are three parts of assessment. First is the patient. Next one is the traction. There is the gadgets, and third one is the limb. The patients, there are several complications like fat embolism, the pulmonary embolism. So how to prevent it? What are the different complications like bed sore? What are the common sites of bed sore? What are the grades of bed sore? How to prevent it? What are the limbs? How to maintain the what are the points to be examined for the limb? That is the length, axis, rotation, deformity. So these are the usual how to prepare this. You have to keep it in your mind.
Okay, great. Thank you very much. I think until next week. Next week is going to be on what?
so that Vikas Agase sir will take only on 5th. That is, I think, case based. Yeah, that one. Sir, here's the topic. I'll just check it, sir.
We will let people know.
Yeah,
Okay.
yeah.
So thank you very much, Professor Pal, and
Mhm.
I'm sure people would have found that useful. And
Yes,
we'll carry on till we see everyone again next week. Okay, bye.
Absolutely.
thank you very much, sir. It's great, sir.
Thank you. Thank you. Bye.
Bye, sir.